cord, you know, it just, that baby is in pain, because that's what that is. So inconsolably crying, can't quiet the baby, etc. That baby's missing out on a lot of developmental input up here. The baby can't sleep. It's waking up, you lay them down, and then in 20 minutes they startle and they're awake. They can't eat. They just drool and just kind of, you know, if you've had one too many some nights and stuff, and it's, oh, no, it never happened in this group, right? No, if the baby can't coordinate to nipple and take in feeding, that's a basic thing. Yeah, we could put a tube in, etc., but if you're doing that in order to get the baby through, that's a red flag. And then if the baby has so much diarrhea that they get a baboon butt. Baboon butt.
Yeah.
That's a visual. Baboons using a red butt. And then, so you're having a whole lot of diarrhea. Those are the four that, of all of those, well, we've had one baby in 8 years that had seizures. So yeah, seizures are kind of not good for you, but we usually don't let withdrawal get that farther along. We don't have seizures. The spontaneous moro goes along with babies not sleeping usually, just a hyperexcitable nervous system. So we talked about them, and that discussion and that process over about 6 to 8 weeks really helped me distill when I would get an order to treat. Clearly, the parents aren't seeing what I'm seeing. They don't have the best interests of the baby at heart. So that's when that line gets crossed. The ones that are working and keeping the baby quiet, really want, I don't want the baby treated because it means they're going to have to stay here for 3 weeks. They've got to be caring about the baby, though. Some of the parents say, I don't want the baby treated, but I know we have to. I can work with those parents, you know.
So your baby that you were just talking about earlier, was the mother still on treatment?
You mean the ones that
The baby that you were on?
need to be treated?
No, the one where you had to get all the ethics committee and everybody together and you were wondering if we should have an order.
Order to treat.
Yeah.
Oh, yeah, there were 2 of them.
But was she still
Both
on
of them.
treatment? Okay.
Both
Were they
of them.
breastfeeding?
Yes, trying
Trying
desperately
to,
to
okay.
breastfeed, and it wasn't all working. They were sleep deprived,
Oh.
never a good state to be in.
Yeah.
And so they're working so hard to do that. And yeah.
So the amount of the drug that gets transmitted through breast milk, from what I'm gathering, sounds minuscule.
You know, I have a slide with how much methadone. There's actually been a very good study done, 9 babies, and they looked at the blood level in the baby and the dose mom took and the amount in the breast milk. And it's a straight line. If you look at it exponentially, it's a straight line. So the baby does get some. And is that enough to absolutely treat the baby? Probably, but so much else, because you know, when we talked about breastfeeding, and I thought about this, one of the things I've learned, moms that were, as little girls were sexually abused, or even as, 9 or 10-year-old, and sometimes the breasts are involved in all that. And some moms cannot deal with, I don't care, even if it's their own baby, putting that baby to breast. They may be able to pump, but having that physical contact just is too much PTSD. They just can't tolerate it. And some don't want to do it at all. So I'm always very careful about how, when we're doing prenatal, how I really talk about breastfeeding. And I essentially will say that, oftentimes we'll say, not every mom wants to or can breastfeed. Sometimes because of trauma and childhood and stuff, they're not able to breastfeed. So I want to let them off. I don't want to pound more guilt into them. But when they can't breastfeed successfully, guess what gets triggered? And feel guilty. I didn't do it right. And life's full of that, So, but neither one of those 2 did we go to DHHS, and they both got through, and both moms, I think, were probably, I don't know how much whether on subject of medicine, and they were trying to breastfeed. Yeah. No, if everyone else want to go to lunch, that's all right.
Sorry. Are there plans in the works somewhere somehow to follow these children?
What?
Are there plans in
To do, there are people that do that. And we have a grant to do it, to get paid for. The Dr. Hayes probably has 180 babies that she has followed, and it's multifactorial. It's socioeconomic driven, it's other drugs, it's alcohol driven. If trying to find out how much a mom smoked during pregnancy or how much alcohol, you don't ask her, how much did you smoke during pregnancy? What are you gonna get? Oh, I had 2 or 3 cigarettes a day, I really cut down. What you ask, and this is well worked out, before you got pregnant, how much alcohol were you drinking? Because a lot of times it doesn't, it directly correlates with what the exposure is during pregnancy. So they use a mass scoring system for alcohol exposure. And there's a cut point that they do in the data where they look at the impact on developmental outcomes. So the higher the alcohol score, in addition to opiate exposure, the worse the developmental outcome. And this is curious, and babies and she's just followed methadone babies so far, but in those babies, probably about 15–20% will actually have a lazy eye that persists into early childhood. So we've really begun to put that on our discharge forms, to be on the lookout for persisting, that's called strabismus, where the eye turns in. Because if it goes unchecked, then you will get blindness in that eye. The brain can't handle the input from 2 different places. It's like looking cross-eyed just drives the brain crazy. So it turns off one of those, and it turns it off permanently. So after a while, so we've seen that.
I'm just wondering, like when they're 7 and then grade 1 or 2, can you say he was definitely in it? You know, we just don't have the data for that.
We don't have the data, and I wish it was that clear, but it isn't going to be. I think what you'll see behavioral stuff, you'll see comorbid, of any other type of thing. It's interesting. We talked about SNPs and genetics of addiction. That also follows with autism. It follows with other types of things that probably have to do with your epigenetics, so turning on and off of genes. So, well, we thought it was all cut and dry. It isn't. It's a lot of other stuff.
What's the average length of these children? Say, when they go home, if they're on, if they continue to be on some, like methadone or something, are we just talking weeks or?
The studies, the programs we've looked at, they go home by about 7 to 10 days after they get stabilized, and will be on it for maybe 2–2.5 months. So it's a much slower wean, and it's much more of a true detoxification, taking the kids down and not really pushing that edge that I talk about, that I do all the time. And I just said, this isn't the right way to treat this baby, but try and get them out of the hospital. You can't leave them in there 45 days and expect a mom who has 2 or 3 kids to try to be in there all the time to be with that baby. I realize I'm doing more harm by leaving that link to state so long. And I'm just caught in the wrong place, and then kind of decided that that's what really the passion behind doing the outpatient treatment program.
Any other questions and concerns?
All right.
Thank you for staying.
Well, I'm going to stay for the next talk.